So thank you very much for the introduction. Cartilage transplantation and osteotomies. The question at first is varus or valgus OA, and where you would like to plan the unloading. And the question is, what is first? Does additional treatment support the osteotomy? And the next question is cartilage lesion. Do we plan a cartilage transplantation, and is additional treatment needed for protect the cartilage procedure? So I would like to go with you through a case. It was originally a 16-year-old male, and he had pain during sports activity. But he was very active because he played football 6 to 7 times per week, and the pain increased. And these are the MRIs in October 2020 from my colleague, and he said there osteochondritis dissecans, and then they go for fixation of this in February 2021. And now in August 2022, you see the disaster of the medial condyle, and the patient is already very young. And so the question is, what can we do for this kind of patient? Now we look to the CT scan, and in the CT scan you see a big part of the bone is already gone, and is meanwhile osteochondritis dissecans grade 4. And so the question is what to do. The deformity analysis present to us a varus deformity of minus 6 degrees, and the MPTA is 84 degrees, and the MLDF is more or less in the norm value. And this was the initial arthroscopic situation. And you see there, the fixation didn't work, and so we had a huge cartilage problem combined with a bony problem in these cases. And so the plan was two-step procedure. At first, restore the bony defect with cancellous bone from the iliac crest, and then we go on with a cartilage transplantation. And so we restore at first the bone. We wait several months until the integration, we are satisfied that we have again the support for the cartilage transplantation. And so that was after the bone grafting, the arthroscopic view in December 2022. And then we go for the cartilage transplantation, autologic cartilage transplantation. You see on the right side of the view, it's already inside, and then it fixed with stitches. And then we go on with a realignment combined with the second part with an open wedge HTO to realign it. It worked pretty well. The goal was a straight leg, not a huge overcorrection, and the bone healed pretty well. And this is 14 months down the road after the first appointment in my hospital. The clinical results. He's go back for sports activity, but my personal recommendation for him was not to go at the same activity level than before, because at the moment the knee works perfectly, but it's not a healthy knee anymore. And so he can go for sports, but I do not recommend to go for contact sports activity. So come back a little bit to the basics. What can we improve, and how can we support cartilage procedures in combination with realignment? There's a very good paper from a Bergman group, and the author was Kutschner, and they analyzed and they put in this study arthroplasties inside the knee, and were able to measure the pressure inside the total knee arthroplasty in vivo. So they have really good results, and they can prove with their TKA patient and in vivo measurements, then 1 degree increase varus means 5% increase of load in the medial compartment. Or the other way around, it means 1 degree correction reduce 5% load in the medial compartment, which is a lot. So we have always to think about this situation. In this study, this was published from the group in Freiburg in Germany. This group, they did a lot of cartilage procedures in Germany, and they did a lot of research work around Philipp Niemeyer. And they have the indication for if they go for a cartilage procedure and malalignment is more than 2 degrees, they combine it with an osteotomy. And you see there they have good results in the combination. Now go to the next paper, which is interesting too, but we have to look to the results very critically because it's a registry analysis of the German cartilage registry, and the data which are inside are limited. So they try to analyze the results of the cartilage procedures combined and without combination of an HDO. You see there on the second part of the data, they have a lot of factors which were not matched in this group. So that they found that not so much of the results have an influence of the result it's not surprising for me, but also so many factors were not matched. If you look to the pain, which is green on the bottom of the first table, you see there was a significant better results regarding pain if you combine the cartilage procedure with an HDO if there is a various deformity. And if you look to if they just ask the patient if they are satisfied or very satisfied in the group which they combined the cartilage procedure with the correction, the very satisfied patient group is much higher than without a correction of the alignment. And so I guess the alignment plays a big role in the cartilage procedure and should be adjusted. So again, these are the groups, but if you see the mean leg axis in the group below 5 degrees, the mean is just 2. So we are already in this group at a border for the recommendation. So clinical outcomes in the 10-year survival rate after HDO and combined with cartilage transplantation. So you see that the survival rate HDO combined with a cartilage procedure is superior. In Germany, the society which is responsible, or the section for cartilage procedures, is the official recommendation. If you go for cartilage procedure and you have a malalignment of more than 3 degrees, you should adjust it. And it's supported by another study from my colleague from my former hospital. We analyzed there the OD combined with realignment procedures. So in summary, analysis of limb alignment in case of cartilage lesion is, in my opinion, absolutely mandatory. And recommendation for an osteotomy is if the axis deviation is more than 3 degrees. At the moment, there is not a really scientific support for this statement, but it is my personal experience, and so it's a statement of the society. And good clinical results are already published, so thank you very much.
Thank you, Professor Steve, for a wonderful presentation. We talked about biology and biomechanics. Any questions from the floor? So I'll start the ball rolling by asking you a question. So you said 3 degree axis deviation, and we saw in previous talks that we could still undercorrect some of these alignment things. So what would your benchmark be? Do you think we should go to the lateral compartment, give slight valgus?
I guess it is really different. We do not talk about osteoarthritis knee. It's isolated cartilage lesion. And in these knees, we would like to support our cartilage procedure. And so I would not recommend to go a huge overcorrection, because usually these are more younger patients, and then they have more problems with the gait if you go for overcorrection. So more the straight leg should be the goal in this patient.
Yeah. So I agree. So I think the message is that the reason why we are doing osteotomy is to protect the cartilage more than to shift it to a more lateral compartment bearing osteotomy. Any other questions from the floor? What cartilage procedures do you normally use? One is the ACI that you showed. Any other?
In Germany, fortunately, I have good access to autological cartilage transplantation. So the results are superior than just microfracturing, but it's a question of costs at the end. So because in my setup, I have in 100% of this patient, I have access to this possibility. So I always use autological cartilage transplantation, even if it is a little bit less than 2 square centimeters, because the results are better than microfracturing. So that is majority of my cases.
Okay. And not for this particular case, but would you think mosaicplasty or anything has a role here?
Sorry?
For mosaicplasty?
If you go for mosaicplasty, is, I think it's not the normal procedure in cartilage lesion. So more if I go for microfracturing, or you go for autological cartilage transplantation. Personally, me, because of my daily practice, I have no experience with the AMIC, with membrane combination. At the moment, there are more and more publications, and they support AMIC as well as a good option to combine it with microfracturing, but I have no personal experience with this kind of treatment.
Great, thanks, thank you. Okay, so we invite the next speaker, Dr. Bhushan, and he'll talk about osteotomy in a cruciate ligament insufficiency.
Morning all, I'm Bhushan Sabnis. It's a tall task to follow Stefan, but it brings us perfectly to in the flow. So he talked about the medial and lateral sides of the knee. Let's talk about cruciate ligament instability and osteotomies. So my talk is on malalignment and instability as a combination, how to tackle that. So a shameless plug-in for an article written by myself. So it's a decent article if you want to look at the review of osteotomy in knee ligament injuries as such. Okay, so most important thing that we need to know in the knee joint is the tibial slope. The tibial slope can be measured by multiple techniques, as you know. The most validated technique is the proximal tibial anatomical axis, and by that generally about 9 to 11 degrees of slope on the medial side and about 6 to 10 degrees on the lateral side is the average slope in Indian population. This has a big relevance in terms of the cruciate load or laxity due to deficiency of either ligaments as such. So in case of ACL laxity, what you need to do is correct the slope in such a way that the instability is corrected. You can achieve that by flattening the tibia or making the tibia more flat or reducing the slope. In case of PCL laxity, that means in patients with a PCL deficient knee, you can increase the slope and that will compensate for your PCL deficiency. I'll explain that in a bit. When we do a standard HTO, generally speaking, because the tibia is shaped in a triangular fashion, you tend to increase the slope when you're doing a medial opening weight osteotomy, and that's why when you do the osteotomy, you open the osteotomy more posteriorly, less anteriorly, and reverse is true for a closing wedge, those to a slightly lesser extent as such. A millimeter increase in the anterior gap will lead to about 2 degrees of slope, so it's about 50% less than what you get. If you place the plate anteriorly, if you place the plate posteriorly versus anteriorly, you can have a difference in the slope that you get. But in general, with every 10 degrees of varus correction, you're going to get about 3 degrees increase in the slope of the tibia. So you need to be cautious about not excessively correcting the varus, because you're also going to get an increase in the slope. So if you have an ACL deficient knee which was asymptomatic, it's now going to become symptomatic. But if you had a PCL deficient knee, then that patient is going to be very happy because the load on the PCL will be reduced and the knee will become stable. So that's a picture from the osteotomy handbook from the AO group, and it just shows how slope changing will lead to the point contact area changing and leading to a reduction in the load on the cruciate ligaments. Okay, so when you're doing a high tibial osteotomy, you want your posterior opening to be around, let's say if it's 10, the anterior has to be 6. So about 60% is the anterior opening as compared to posterior opening. So if you look at this image, the posterior opening is 10, anterior opening is around 6 to 7. So this is the way in which you maintain the slope whenever you are doing a high tibial osteotomy, and this is beneficial for people or patients with a slight deficiency of ACL. Now mark my words, I say slight deficiency. When I say that, I mean asymptomatic ACL deficiency or a partially injured ACL. For a patient with a ACL injury, if you maintain the slope or if you increase the slope, they are going to become quite problematic. So in such patients, you need to flatten the slope as much as possible by opening it more posteriorly, less anteriorly. For that, you might have to break the hinge as well. And the reverse is true. And the reverse is true when you're doing a PCL. So that's a quick example of extension valgizing osteotomy. You break the hinge and purposely change the slope of the tibia to get the tibia flattened. Sometimes you want to do it in a formal way, and this is how I do a slope changing osteotomy. So this patient is 37 and she has a slope of around 18 degrees. And the way we are going to correct it is by this osteotomy. This is called as a biological plate concept. So you lift off the anterior tibial cortex with the tibial tubercle as well. So everything is lifted anteriorly, and now you got a nice flat surface to do your osteotomy. You decide what your plan is and take out the wedge as you would normally take, and then close it anteriorly. That way you are flattening the joint and getting the tibial slope flattened. I generally do not put a plate on the medial side if I got a good biological plate. So this is called as a biological plate. This is called as a biological plate. So the tibial tubercle itself is acting as a plate on the front. I've added a medial plate along with this because the bone was quite osteoporotic in this patient, and that leads to a really nice fixation. So you can see there's a revision ACL as well there, and the biological plate is holding nicely and the slope is completely flat. So this patient did really well. From that slope, it came to almost neutral. So this is the standard way in which you can do a extension osteotomy or flatten the tibial slope. In patients who have a malunited proximal tibial fracture or reversal of slope with a PCL deficiency, you need to do something to increase the slope, and this is the slope extension, increasing osteotomy or flexion osteotomy as you call it. So essentially what you're planning to do is put a bone graft on the anterior tibia so that your slope is increasing. This is how you plan it actually on a software, and that's how it's going to look at the end. So same principle, you're lifting the anterior tibial tubercle off as a single layer, and then you got a flat surface of the proximal tibia to correct the deformity. We are talking in sagittal plane, so you're operating from the front of the tibia, and then you put the bone graft in and close the biological plate on top. So that's how it looks. So as you can see, the thing which is pointing up is a tibial tubercle which is completely detached. You got a flat surface now. You have opened a nice cut on the front, and you put some bone graft inside, and that's intraoperative. You can see there's a biological plate now sitting exactly where it should be, and all you need to do is just fix it with multiple screws such as this, and you got a nice increase in the slope in these patients. So this is the way in which you can do a slope flattening or slope increasing osteotomy. I'm purposely avoiding calling them extension and flexion osteotomy for confusion. Sometimes you can combine the two. So you can do ACL reconstruction along with HTO. You can do PCL reconstruction along with HTO. That's the example of ACL plus HTO. You can use different kinds of plate. You can have plates with swivels as you saw in the surgery just now, or you can have variable angle plates such as the peak plates, or you can use specialized plates which are L-shaped where the vertical limb of the L can come anterior posterior depending on your preference as such. You can combine HTO and PCL at the same time. So it's slightly tricky to do it, but you can do it. Not a very tall task in terms of standard osteotomy, but the PCL reconstruction takes a bit of time due to the position in the screws. So you have to superiorize the plate or proximalize the plate a bit to have sufficient space for the PCL tibial tunnel. If you look at this image on the side, you can see the tibial tunnel is lateral, and quite a few times I do this for PCL reconstruction where I put the tibial tunnel laterally if it's coming in the way of the plates as such. But what's more important is to get the alignment perfectly straight when you're doing a ligament reconstruction. Okay, so there are three scenarios that you are going to face. There are patients who will come with symptomatic varus deformity, and you get an incidental diagnosis of asymptomatic ACL or PCL deficiency on the MRI. There are patients who are going to come with symptomatic instability, where there's asymptomatic valgus or varus, or you'll get patients with both instability plus malalignment being symptomatic. So these patients, these are the options. So for scenario 1, you can do a simple osteotomy because the ACL and PCL deficiency was asymptomatic. Bearing in mind any slope change can cause the patient to become symptomatic, so you need to make sure the slope is not changed or changed in your favor. For patients with scenario 2, you can do a simple ligament reconstruction and warn the patient that he may need an osteotomy. And lastly, if both are symptomatic, you have to combine both a ligament reconstruction and osteotomy. There is a fourth scenario where you have a chronic instability with arthritic changes. In such patients, I think ligament reconstruction is generally not a good idea, and you can just do an osteotomy with a slope change as such. I was going to quote a lot of papers about this, so I won't quote any of these, but there are a lot of studies which show a slope change works really favorably in most patients, including cadaveric studies and patient studies as well. I would just like to show one paper. This is a paper from Korea, from China, where they did a primary ACL reconstruction with slope correction in first instance, which is slightly over the top in my opinion. So we normally do slope changing surgeries for a revision ACL or PCL reconstruction. So does that mean we should be looking at tibial slope for every patient undergoing ACLR? I think yes. Can slope change be performed as primary procedure? Slightly controversial. If there is a significantly bad altered slope, then you can change it, of course. And in low demand patients, can we just get away with slope change and not do a ligament reconstruction? That's slightly controversial. So hope that made sense and didn't confuse you more. Thank you.
So thanks, Bhushan, for such a wonderful explanation of when to do what. Any questions from the floor? I think everyone has understood it very well. So thank you, Bhushan. Oh no, there's one.
How does the patient experience the benefit of the surgery, of the slope change? I mean, you would have done a good job, yes. Does the patient experience a change in the
Yes, the
feet
knee
of the
becomes very stable almost immediately. The moment start weight bearing, they realize the knee is stable now. So you got to
Because as it is, when you started off itself, it was just it was not a gross ACL insufficiency. It was, a laxity that you have found.
So
The patient may be asymptomatic also.
yeah, so for asymptomatic ACL tears in a patient with varus malalignment, I would just correct the deformity. I will not touch the ACL at this juncture, but I'll make sure I'm not increasing the slope because that will make him symptomatic. That's what I meant. For someone with a symptomatic ACL laxity and a symptomatic varus deformity, I would do both. And the patients start feeling the knee to be superbly stable the moment the slope change is done. For the patients I showed a slope changing osteotomy, they are really, really happy the moment slope change is healed and they start weight bearing. They're very happy post-operatively generally.
So thank you, Bhushan. May I invite the next speaker, my friend Mukesh, and he'll be talking on challenges and precautions in alignment correction osteotomies.
Good morning, everyone. It's nice to be here where I have learned thanks to Dr. David Rajan sir and his team. So the first and the most important challenge, do you believe that cartilage regenerate and does cartilage have regenerative capacity? A lot of articles are there. The recent one in 2024, they say on relook arthroscopy after HTO, cartilage regrow. And my own patient, she was 42-year-old female with grade 4 AMOA, possibly complete grade 4 AMOA. I did osteotomy 5 years back and at the implant removal, you can see the cartilage regrow without any cartilage regenerative procedure. You just need to give favorable condition for the cartilage to regrow. So the first important challenge that cartilage have regenerative capacity, so think about it. The second challenge, what is proper imaging? You should have a proper scanogram where the patella is centered, the proximal 1/3 tibiofibular overlap, the condyles facing to in front of you. If patella is outside and there is too much of overlap, that's not a correct scanogram. So get a proper scanogram and imaging. It should always be calibrated to do proper calculations. Lateral scanogram, if you can do, you can measure the slope. Routine standing AP X-ray to know the JLCA, which is very important. And of course, lateral X-ray is a must to see if it's already patella baha, then you need to change the slope of the osteotomy. This is the second challenge which you need to understand. The third challenge is correct indication. These all scanograms are young arthritic knee below 40 or 50 years of age, but one is varus with ligament laxity, one is intra-articular varus, one severe varus with dual deformity, means both in femur and tibia, and the other one is metaphyseal tibial varus. So these are the varus deformities, but only one surgery doesn't work in it. So you need to have a correct indication, and then you need to implement it. And when not to do in case of inflammatory arthritis, in case of tricompartmental arthritis, senior patient, very high BMI with arthritic knee, be careful, don't do knee preservation surgeries. And then you should have a proper scanogram or proper measurements, calculations, either on pen or paper, or nowadays you have very good digital calculators and all, where you can actually do osteotomy even before surgery, and you can measure how much alteration you are doing in MPTA, MLDFA. So proper calculation is another challenge. Believe in cartilage regeneration, do proper indication, do proper imaging, and do proper calculations. Then you can be a good, successful knee preservation surgeries. Surgical precautions, MCL release or transaction. You can do a good MCL release, but nowadays what I am doing is I just raise the whole pes bursa flap, and then that's the complete intact MCL. I release it posteriorly and I directly transect the MCL because the osteotomy is 4 centimeter distally. So transecting MCL or releasing doesn't make any difference. It's what you believe in. You can go with both. The length and the height of the osteotomy. Tip of the fibula is a very good landmark, but sometimes the fibula is very high. So it should be 1.5 centimeter distal to the lateral tibial plateau, and the osteotomy on the medial side should be around 4 centimeter distal to the medial tibial plateau. That you should take so that you don't land up in such kind of complications where your osteotomy is too high and you have caused the fracture and the fibula was too high. So 1.5 centimeter from lateral tibial plateau and 4 centimeter from medial tibial plateau. Always use hinge wire. Those two osteotomy wires should be parallel to each other to avoid oblique plane of the osteotomy. They should be parallel from medial to lateral. And once you finish osteotomy, it should be very supple and it should open like this and close. That means the hinge is intact and medially you have done a good MCL release. So proper plain and supple opening should be there. Always try and maintain the slope whenever you are doing medial open wedge osteotomy. So the posterior half should open double the anterior half. That means you have retained the original slope of the patient. Now, many times we find it tough to maintain the correction. We end up either overcorrecting or undercorrecting. We have seen a nice surgery by Bhushan in the morning where he had put the lamina spreader. Sometimes lamina spreader just slips out, or in osteoporotic bone, it crushes the bone. What I have done, even the literature says now putting this tricalcium phosphate synthetic augments causing non-unions. So what I've done, I've started using only about 1 to 1.5 centimeter of this synthetic and used it as a block only on medial aspect. It stabilizes your osteotomy very well on the table, and then you are neither undercorrect nor overcorrect, and you can easily put the plate without any hassle bustle by stabilizing, putting that 1.5 centimeter synthetic block. And can you do bilateral in one sitting? Yes, of course you can do, but patient should be non-smoker, non-diabetic, BMI should be less, well motivated, well explained what are we going to do. As in this patient, he has bilateral metaphyseal varus with grade 3 arthritis. I did bilateral osteotomy in one go, fixed because of good plates, and they can be mobilized on day 1 with full weight bearing with the help of walker. Do give DVT prophylaxis, tranexamic acid to reduce the bleeding, and I always put drain if I am doing bilateral. So post-op day 14, and within 3 months they are back to normal even after you do a good bilateral in single sitting. But be precautious that they should be non-diabetic, non-smoker particularly. She is 47-year-old female with bilateral varus, arthritic knee, osteoporotic, post-menopausal. So I have done it in single sitting. Whenever it's grade 4, go up to little beyond the normal alignment. I've used bone grafting in this patient because of associated osteoporosis and to avoid any failure or non-unions. Young female with severe valgus, where you have valgus in femur, tibia everywhere, you can do all closed wedge 3 osteotomies in one go, and still you can mobilize them where, because it's all closed wedge osteotomies, you have not broken the hinge, and that's why they are inherently stable, and that's the girl walking and doing day 1 as well as 1 year post-op, all activities are done. So bilateral open wedge osteotomies work well and they have good scorings. When it comes to middle-aged females like this, grade 4 arthritis in middle-aged female, severe 17-18 degree varus, if you do only on tibia, you will alter the joint line. The MPT is going to 98, you get good alignment, but 98, so plan and do dual osteotomy, biplanar both on femur and tibia. Even if you do close, they have excellent stability and more surface healing area. So did bilateral dual osteotomy in this female, correcting the alignment even in grade 4, and this is the 4.5 years follow-up. Patient is still asymptomatic, doing all activities whatever she wants. A farmer by occupation, 50-year-old, severe valgus arthritic knee, again a dual osteotomy works well if you plan it well, and the farmer can go back to its original level of activities after doing a knee preservation surgeries. So dual osteotomy also works very well. So I think the biggest challenge is correct indication, and the precaution you should take is do correct surgical execution depending on the various pathologies. Thank you. All done.
Excellent talk and summarization of a lot of controversies. Any questions from the floor?
Morning, sir. So when you do bilateral dual osteotomy, you do it in the same sitting for both the legs?
No, I have still not developed that courage of doing 4 osteotomies in one go.
Okay. In interval of
Yeah,
some
one
days?
side first, and then after 3 months, other side.
Okay. Thank you.
No, I think you explained it well. Thanks, Mukesh.
Thank you.
Thank you. May I invite the next speaker, once again, Professor Stephen, for failed osteotomy around the knee.
So failed osteotomies around the knee. We talk about at the moment about our successful procedures, but not always everything will be successful in our hands. I will let you know a lot about my experience and how we can avoid failure and how we can treat them, well, failed osteotomies. So at first I come to the topic planning. That is the starting point where we can make a lot of mistakes or we can avoid any failure in our treatment because we need a correct X-ray. We mentioned this morning already that the position of the knee, that we have really a forward pointed knee, it's important that it make a big difference. It is already published. And what are the quality criteria? Patella should look forward. The knee is AP, and if the knee is AP and you have no malalignment and torsion, you should see the trochanter minor should be visible. The proximal tibiofibular joint should be just 1/3 of the proximal fibula should be behind the tibia. Remember the case in our panel discussion where we had one case and most of the proximal fibula was completely behind the tibia, which is a topic of torsion usually or rotation. And the shape of the femur condyle should look normal in a true AP position. And if you do not have this in this visible situation, then you should look about the rotation and or the torsion of the leg. The next is planning the osteotomy on the right bone. You see there a huge overcorrection after a correction medial closed wedge osteotomy, and the result was a huge varus. you can correct it at a tibia for sure, and then you have a straight leg afterwards, but you have a huge oblique joint line. And so if you correct it on the wrong bone, also the bone will be straight, the patient will be not happy with such a situation. So this is not a good solution. So the solution is to go in such a case for an open wedge medial and correct it on the correct bone. The next topic is that you need sometimes stress X-rays, because not every medial osteoarthritis is the case of correction. If there is completely no deformity and you would like just to correct the interarticular deformity in the middle-aged patient, then probably the uni is the better option for the patient, because you would like to treat deformity and not create new deformities in the patient. And the alignment and the stress X-rays are very helpful to get a better impression about the ligament laxities, especially if you have a huge varus. Sometimes you have a huge lateral laxity or medial laxity, and you do not know how you end up with the alignment if you go in a little bit overcorrection, and because afterwards the joint could be open medially, and then your whole simulation is not correct, and you end up in a huge overcorrection. And sometimes it is helpful to go for stress X-rays in the long leg standing X-rays. And then the simulation plan, which I mentioned already, on the correct bone according to your deformity analysis, that helps a lot to avoid the mistakes. Second topic, hinge fractures of the tibia. It was defined or described already by Ryo Takeuchi from Japan, and he defined it very precisely. The type 1 fracture, which runs above the fibular head, and type 2 below, and type 3 inside the joint. These are all my personal pictures. It's not from somebody else. It's for the beginning of my career. And then the type 3 is a mistake during the procedure. If you do not cut posterolaterally where the vessels are, then you can create a type 3 fracture. So it's always, it's for me more a mistake than a complication. And I have all my type 3 fracture in my first cases. Meanwhile, I do not have it anymore. So, and I present you a case which I did by myself. It was an old lady. That was the simulation. We have the OA, medial compartment, varus, and I would like to correct it to the degree of varus. That was the intraoperative X-rays, and to be honest, I was satisfied with the results. It looks beautiful, and the patient can walk with partial weight bearing, and so I was happy. And then 6 weeks down the road, the patient come for the control to me in the outpatient clinic back, and that were the X-rays, and this was the alignment, huge overcorrection, and this was the lady, and so I guess this alignment is not acceptable for such a lady, because if you look to these knocking knees, the patient, she even if the bone will heal, but she cannot walk, so you have to go for revision. But what was the reason? The reason is we have an angular locking plate, and if with the pre-bending of the golden screw, then you can probably introduce a hinge type 2 fracture in the aftercare or in the rehabilitation, and then your hinge point moved from lateral more to medial, and then the opening is still the same, and then the result is the overcorrection, because the opening angle increase and is not according to your planning anymore. So what we can do, we go back, we start, remove the plate, go lateral, go for checking the alignment, that we have a better impression, because you cannot simulate everything. And then you know, okay, this is the alignment we have, fix it with, I use always a 5-hole 3.5 LCP, bend it according to anatomy, fix it. And if I go for revision, I like to go for bone grafting to make it very safe, but just cancellous bone, no wedges, just cancellous bone inside. And then I can fix the plate proximal and adjust it with the tension device according my plan, how the alignment should be during the procedures, and fix it again. And this is 9 months down the road after the revision. You see, it's an old lady. She's, I guess, 73, and she was happy with the final result. So we can even end up with good results. So hinge protection, the wire, we saw this today already, and it's published. My personal experience are not so successful, so I do not use it. This was one of the cases I used it, and the result was that the fracture runs directly along the wire at a type 1 fracture, and we have a dislocation. It's a dislocated hinge, and the question is, how can we deal with this situation? Just fix it is not a good solution, and that is just a tip how you can solve this problem. It's a translation of the tibial head, and if you just go up with the spreader, then you can go for the reduction of the proximal tibia, and then you fix it with the ankle locking plate, and then everything is done, and the final result looks like a normal osteotomy, and so you will not have any problems. Hinge fracture for the femur. Nakayama, Hiroshi Nakayama from Japan defined two types. Type 1, if it runs directly in the same line, and if it goes upwards, it's type 2. Again, case of a double level, I start always with the femur, and then you see there a fracture. It is always not a very good situation during the situation if this is the starting point of a double level osteotomy, but you go in the same way. You have to fix it with a reduction and with a plate, and this is the result of the hinge protection and reduction, and it looks beautiful, and then we can go on with the open wedge HDO and it up with a good result of the double level. Patient was happy. A few months later on, he asked for the other leg, and we corrected, in this case, without a hinge fracture. Second case, again, double level. I closed the osteotomy, and it looks beautiful. But if you look very precisely, you see there a fracture at a hinge. And the question is, should we fix it or not in such a case? And this is the patient. And you look about his normal exercises he is doing. And if you think about such a patient, I am very critical, and I do not promise his compliance. And so in such a patient, I would like to fix it with a hinge screw. Meanwhile, it helps a lot, and it heals without any problems. And there you see the patient after the osteotomies, the weight decrease, but he still go for exercises, and without a hinge protection, I would be afraid on stabilizing the femur. It is already published, the stability in a biomechanical or finite elemente analysis. So the hinge protection wire works pretty well, and it's published in several publications that we really decrease the rate of hinge fracture at a femur if you use it, and for me it's not meanwhile routinely used. So vessel lesions, we know the vessels are close to the posterior part, and that is a horrible complication. And how can we avoid it? The first is that we are aware where the vessels are, that we protect it. We saw today very beautiful from Bushan the technique and the protection with the retractor in the posterior part. But I would like to give you a little bit more insight in this procedure. There you see several possibilities of protection with different retractors. But look at this MRI. Usually we have an MRI preoperatively. I didn't look to the MRI in that case because the problem was the medial compartment. But look at that, where the vessels are. And if you go with the retractor which you saw today with Bushan, you will be not able to protect these vessels because they will be in front of your retractor. And you see there are now two incisions because it's very impressive how it can bleed during an osteotomy. And so I solved the problem, patient was happy, but the patient asked for the other leg. They have the same anatomy. And so that was after the first, and again, he was happy. And then the other side, you see the approach was completely different. I go very precisely at the bone on the other leg, and you can solve the problem if you are aware where the vessels are preoperatively. So my recommendation is look to the MRI where the vessels are. It's very rare, the situation with the vessels, but if you have the problem in the OR, it's a big problem. So, and this is the final results of this patient. So came to the take-home message. Quality of long leg, a full weight-bearing X-ray is important. If hinge fracture result in overcorrection, indication of revision is there. Reduction of dislocated hinge fracture while surgery is definitively required, and fixation of the dislocated hinge fractures by a blade is recommended. And fixation of simple fracture is a screw at a femur, in my opinion, enough. And be aware on the vessel anatomy. So thank you very much.
So brilliant talk, and you've summarized everything that can go wrong and should not go wrong, and how to correct that. So really, a very good lecture. Any questions from the floor?
Morning, sir. I have two questions, sir. You showed one case where after putting the hinge wire, you had a hinge fracture and the fracture got displaced. So while reducing, how do you maintain the rotation? Will there be any problem in the reduction regarding rotation?
Very good question. If you have a biplanar osteotomy, you have in the anterior ascending cut, you have an orientation for rotation. If you have there an opening in the ascending part of the osteotomy, then you know there's a problem of the rotation, so you can observe it. But usually in this case, it's not a problem. If you just rotate the spreader, you can go for the reduction, and there's usually no problem. But you can check it during the surgery with the biplanar osteotomy.
My second question is, while you're doing the osteotomy, like you said, and there was a subtle fracture at the hinge, we are not able to detect intraoperatively. Maybe in the post-op X-ray, if you find a fracture, in those cases, how will the rehab, do you non-weight bear, will it help in the healing, or revision is the only?
I guess that is a very individual decision with the patient, because if you're already out of the OR, the recommendation could be we go back in the OR to fix it, to make it safe. But I would go with, if you have an obese patient and I would not trust regarding his partial weight bearing, then I would go back, because if you have a completely disaster and the femur, it's always very difficult. If you trust the patient, then I would recommend for partial weight bearing until you see the bone healing. And it could be 6 or 8 weeks. Yeah.
Thank you.
Sir, so the recommendation will be hinge wire or hinge screw in all osteotomies now? Current recommendation.
During the procedure, I recommend the hinge wire. And the hinge screw, I just put it if I have a hinge fracture or if I have really a very heavy patient. I do not use the hinge screw routinely.
Thank you.
Okay, you want to have a question? Okay, no question. Thank you, Professor Steve, for a wonderful thing, and thank you all the speakers for the wonderful sessions. And I think we move on to a panel discussion now.
I invite Dr. Sundarajan sir for the panel discussion. I request Vaibhav sir to stay back, and thank you, Dr. Geethan sir. I request Dr. Stephen, Dr. Mukesh, and Dr. Bhushan to chair the session.
Good morning, everyone. And I think Geethan has covered a few of the topics in the last panel discussion. So I will try to sometimes rush through or sometimes re-emphasize on some points which you want to know, especially for the basics and in the knee preservation. So we'll go with the case one. It's a 50-year-old female patient. It's an insidious onset knee pain since 1 year duration, aggravated on squatting and sitting cross-legged. It's a mild effusion on the knee joint. Movements are almost full except the terminal restrictions. She was treated with the medications, exercises with the conservative management, and this is the X-ray of the same patient. So it's a 1 year duration, 50-year-old female patients. And what is your regular go after seeing this kind of patients in your outpatient department? Can you start with Bhushan? What will you do? So 1 year failed conservative management for 1 year, that was the X-ray. 50 years.
So we'll start investigating this further if it's failed the basic conservative management. So let's get a scanogram and a MRI done and see how it goes.
So anyone will try steroid without doing an alignment X-ray or an MRI scan?
I think
Mukesh, because this was a widespread practice of giving a steroid in this kind of patients with the failed management in some centers. So anyone?
I think we should investigate, see what we're dealing with, and then decide on the management.
Right, investigate thoroughly and then decide.
I think the message is clear that so you should not give a steroid without knowing the exact diagnosis. So every patient has got a proper diagnosis. So you should go ahead with an MRI scan you should go for an alignment X-ray to go for the treatment. Okay? So that is a message which you have to know. Please don't give any steroid for a patient which is reasonably maintain the joint space in a younger patients without much arthritis. And this is then alignment X-ray for that particular patient. The right side, I think it's a 2.5. On the left side, I think it's a 5.1. Okay, so 5. And that is the MRI. So you can see that coronal axial view shows the root tear. So instead of wasting time, so what is your line of management? Start with the Stefan.
Yeah, if there's the varus alignment combined with the root here, right?
Yes, it's a 5.1 and left side is a 2.8 or something.
Yeah, I would. The left side is 2.8.
So left side is 5.
Left side is 5. Okay.
Yeah.
So
that is a symptomatic side.
Yeah, I would go for correction of the alignment combined with root fixation. In the MRI, the meniscus quality looks good, so I would try to fix the root.
Mukesh.
I'll go for simple root repair.
I like this. I want this controversy only.
5 degrees.
Osteotomy man. Bhushan.
Come on, Mukesh. 5 degrees varus is a massive varus. We need to correct that. So, of course, we'll do HTO. Whether to do root repair or not depends on the quality of the meniscus when you're scooping it.
Yeah.
So when you say 5 degrees of varus, you want the knee to be in about 3 to 4 degrees of valgus. So we are going to do at least 7 or 8 millimeter correction. It's not a 3 or 5 millimeter correction we are thinking of. So you want to offload the medial compartment. So of course HTO plus minus root repair.
Okay, now even after seeing the cartilage, see the case. That is the medial compartment.
It's not bad.
Can you see any? I mean, you see that this patient, of course, he doesn't have any arthritis at all. Stefan.
No, the question for the osteotomy is for me not the cartilage. It's to support the unloading of the knee and to support the root fixation. Because I guess the root will not heal completely in 6 weeks. I guess this tissue needs more time. And if I go for unloading, and we know from, I presented a study from the Bergman group, 5% per 1 degree. If I correct 5 degrees, I reduce the load in the medial compartment of 25%. And in my opinion, that is a lot to support the fixation. If everything works well, you are right, then the patient do not need us. But I guess we can support the treatment.
I understand that because this is a border, it's a 5 degrees, the literature, you see the border. See, it's a less than 5 degrees with this, you don't need of correction. If anything goes on more than 5 degrees, then you require a correction with that's what the recommendations is in general now. So that because this is in the border of 5 degrees with a normal cartilage, of course it's a controversial. That's why all of you are giving a different opinion. So anything is more than 5 degree, 100%. I think we think that you have to offload it. And this patient, because even I didn't do an osteotomy because this patient had almost close to the 3 degrees on the opposite side. This is just 5 degrees. So that's why I didn't do an osteotomy for this patient. It's because not a severe varus and the opposite side had around 3 degrees varus. So this patient, I think we did just a simple root repair for this patient, and this patient is doing well. Anyway, before taking a root repair decision, I think for the youngsters, for the common root repair indications, I think all of us should know that anything with the grade 4 arthritis, the root repair alone may not work very well. I think before that, we should diagnose if the patient has got any sponk. That is very, very important. As already Mukesh also mentioned in the last panel discussions, so clinically examine the proximal tibia. Look for the medial side tenderness because that patient might be having a varus deformity. Sometimes they will come with the tibial stress syndrome. So that is totally a different entity, but MRI may show root tear and other things. But anybody with the tibial stress syndrome, just treat the tibial stress syndrome with unloading brace, that patients will become all right. Unless they come back with, again, other complaint, we should not operate for a root repair. Of course, severe malalignment, which I already told, the isolated root repair will not work, which we discussed. So move on to the next case. Is a 42 years old female patient, right knee pain for 3 months. And that is the patient which you can see that there's a very painful gait. This walks with very painful gait. And that was the X-ray. You can see that reasonably maintain the joint space on the right side, and you can see this alignment is 4.3 degrees. Just I had put this X-ray, this case mainly because you see the other side, this patient had an arthroscopic middle meniscus root repair with the ACL decompression, had almost grade 4 OA on the other side. It was done a microfracture. It was done 4.5 years before. But really I couldn't remember or recollect whether what was the alignment at that time. Sorry, I couldn't get that X-ray because patient also lost it. I didn't have it. Just I wanted to show this case. Why? Because it's 4.5 years old. Now this shows 9 degrees varus. So now patient comes with pain on the right side. I think probably the more varus on the opposite side put on a stress on this side. So many times we see that when the patient, when we discussed last panel discussion also, when you have a more varus with the grade 4 arthritis, the patient comes back with the opposite side of grade 1, 2 OA with the root. So that is the starting stage of your arthritis. So this is same. You can see the other side is almost 9 degrees varus. This side is only 4 degrees varus. That put a lot of stress. These patients had a root tear, but alignment is reasonable here. In this case, it's around 4.2. I'm sure that some of you may do along with the osteotomy also for this patient because this patient had a problem in the other side also because the varus deformity has progressed. Okay, this is the same side. So along with the ACL decompression, maybe this, I don't know, this may help or we don't know. Already we discussed whether to do an extrusion correction or not because you see the cartilage of these patients looks still very good. Even though it's a 4 degrees varus, you see the cartilage is almost like 0. You don't have even a grade 1 or 2. So this patient, I did a centralization, but we don't know it's going to work or not. Yes, Manadi already we had a very good debate. So I didn't want to waste your time. So this patient I did a correction, but I didn't do an osteotomy. But you see that I had a chance to put on a scopy on the opposite side. Even though this patient had a 9 degrees varus, 4.5 years follow-up, you see that is a microfracture which shows like with good cartilage healing. And the root, you can see that the root also has healed well. So this patient, I think, still tolerating with that root repair with the microfracture healing. I'm not sure, but still patient doesn't have a pain on the other opposite side. But anyway, it put a lot of stress on the right side, now resulted in the root tear and starting stage of the osteoarthritis. Mainly this case to show that you can see how the osteoarthritis starts with the root tear. Okay, any comments? Bhushan?
That's a typical way a lot of patients present. So they are more painful on the less severely affected side. And I think that's because the one knee is trying to protect the other knee. When they're walking, they're trying to offload the affected or damaged joint by loading the part which is less damaged, and that takes the brunt of things. On the MRI, a lot of times you see bone edema on those.
And also it's because it's a virgin knee before that, probably whether we should have corrected the varus properly on the opposite side, probably that would put a less stress on this side. This might have slowed the root tear for this side, opposite side.
That's always the question. So if this patient comes to me for HTO, I'm always slightly confused which side to be done first, whether the side that looks bad on the X-ray to be done first, or the side which the patient presents to be done first. So I've realized it's not easy to argue with patients, and it's better to just do the painful side first, but warn them that this has happened because of the other side, so other side in about 3 months' time, or as Mukesh does it, both sides at the same time.
Yes, I mean, I told the patient also you may need an osteotomy, or if the patient develops pain, but at present that patient doesn't have any complaint on this side, that varus side. That is the problem. So you come with only for the root pain in the right side with the root tear, with the normal cartilage. So this is maybe this is one of the good example case to show that how that alignment problem on the opposite side put under stress, and that increases the hoop stresses resulting in a root tear. Naturally, if you don't do a root repair, it's going to accelerate your osteoarthritis. Stefan, any different opinion?
No, I guess it is a perfect example for our daily practice that not always our X-rays fits to the complaints to the patient, and so we cannot treat just the X-rays or the MRIs. We have to include the complaints of the patient, and then we have to make with them together the decision what should we do first and what will be the advantage for the patient. Because The patient is not coming usually not because of the varus, not because of an MRI. They comes in our outpatient clinic because they have pain and disability, and so we have to think about the original problem of the patient.
So this is we'll go to move on to the next case. Is a 38 years old male patient, pain in the right knee for 8 months. Even though the topic, the conference topic is the aging knee, so you see the aging knee starts at 38 years old, not a 58 years old for Vaibhav, for arthroplasty surgeons. So that's why this panel discussion was about it. So this is a 38 years old case. We can see that reasonably maintained joint space with a long, you can see that there is a varus deformity of both the sides, 8 degrees and 9 degrees. And you can see the joint line convergence angles is 3.2, that the typical root tear and typical varus deformity. And this is how the extrusion shows. It's a 4 mm extrusion, and we can see that is the grade 2 cartilage edges. I think this can be this is the ideal indications for to do a root repair, because I want to show this case why that case is only a root tear. This is a 9 degrees varus, not like a 5 degrees or 4 degrees in the borderline. So this case you had to combine with osteotomy. So you can see that this patient underwent a root tear. Of course, this patient, even though the cartilage is normal with a 9 degrees varus, if you don't do the osteotomy, it is going to put again stress on the root, and may not heal, and your cartilage degeneration going to progress. So this patient needs a root repair and osteotomy along with that. So case 4 is a 45 years old female, the pain in the right knee for 1 year duration. You see all the age group is all 35 to 45, which I am talking about, because most of the patients are coming like this. And we can see that is the X-ray, varus around, I think, 7.3 degrees varus, LDFA 91 and MPT 84. That is the MRI, shows the coronal. I can see the extrusions, and they can see the sagittal view. Okay, so just to save the time, it's okay. Just say it's a OA, but no root tear, with a grade 3 to 4, as you see in the X-ray. 7.3 degrees of varus. So what do you do? It's a varus deformity, failed conservative management. Mukesh or Vaibhav?
I think this is a good case for an HTO, so I think that's what we'll do.
Okay, so anybody will do any other uni or something like that? Because it's a grade 4 arthritis, grade 3 to 4. Stefan?
What is the exact alignment?
7.6.
And
Varus.
the MPTA?
MPTA is 84.
LDFA
LDFA is a 91.
And the pain of the patient, is he still able to walk, or is it completely?
A patient is walking, but with the pain.
Then for me it's an indication for knee preservation, then it's not an indication for a uni.
So okay, so all of us agree that it's a grade 3 to 4. This is slightly extended indication for the osteotomy. That's why I wanted to put this case. The previous cases were grade 1 and 2. There are ideal indications. I think these are all the extended indications for this age group, because we don't have much options, so we cannot go for a replacement for these patients. We can see that is the arthroscopic view. You can see this almost grade 3 on the femoral side. There are focal, again grade 4 on the tibial side too. And you see that horizontal tear, there's a typical OA tears. And also you can see it's a very unstable meniscus. When I put a probe here, you see the whole of the posterior horn of the meniscus is coming into the joint. So you can see that it's a very unstable flaps, arthritis. So these are some cases where, apart from osteotomy, we do some repair, stabilize the meniscus, because when we discussed about the talk with David Rajan sir spoke about aging knee, the role of preservation. Maybe this is 1 or 2 cases where you do the horizontal tear repair, stabilize the posterior horn of the meniscus to the posterior capsule by doing a all-inside technique. And here what we have done is that meniscus repair, did a microfracture for the small fragment here, and we had to do osteotomy. So this case, anybody will do any biology? So that is the question which I want to bring it along with this, because maximally with this all we can do. You stabilize the meniscus, you did some microfracture, Anybody had any biology in your routine practice? Bhushan?
I'm not a big fan of microfractures, unfortunately, but I think taking off damaged cartilage makes sense. I would rather think of something like, not in this case, of course, oats or mosaic-plasty in patients who have cartilage lesions such as that. But yes, you need to add something in terms of biology. So even injections of whatever the newer things, stem cells and other allogenic stem cells also can be thought of. But I think alignment comes primarily.
Yeah, of course, we done corrected the alignment. I mean, you want to, I don't do the biologies, I don't do a PRP. I want to get opinion from the floor.
Only HTO.
Only HTO unless some mechanical symptom like locking. I will not even do a scopy for that.
Stephen?
At the moment, I would do in this case just HTO as well, but I guess the meniscus fixation, and we saw today that we reduced the extrusion with anchor fixation, and I guess these procedures are done since a few years in this combination, and I guess we miss at the moment the scientific evidence, and probably you're right, and probably in the future we do much more with the meniscus, even in this degenerative knees. And the Japanese colleagues, they do since many years, especially in a grade 4 osteoarthritis, they go for meniscus refixation. So probably that will be the future. But at the moment, my daily practice, I would not do it.
Yeah, so in this case, I didn't do any extrusion correction, but you can see the whole meniscus was mobile here. The whole posterior horn was with the horizontal flaps mobile. That's why I wanted to stabilize that meniscus to give the stability. This is a 64-year-old female. Sir, if you have time or Sandosh? Shall I go ahead? So a 64-year-old female, pain in the right knee for more than 3 months' time, aggravated inactivities, and alignment is around, you can see the right side around 10 degrees and the left side is 11.3 degrees, and wedge is corrected, correction comes to 13, and that is a typical posterior root tear of the meniscus, and also changes in the grade 1 to 2 patellofemoral arthritis. So how does it influences your osteotomy decision when you have a patellofemoral joint grade 1, 2 or 3? We know that when you put a open osteotomy, it's going to put a more stress on the patellofemoral joint. So what is your Bhushan, your cutoff?
I think in patient, the patellofemoral joint does not like valgus. It loves varus alignment. So anytime you valgize the knee or do a high tibial osteotomy, the PFJ pain worsens in patients who already have a pre-existing patellofemoral arthritis. So someone with grade 3, grade 4, you should not be doing an osteotomy essentially. Actually, in practice, we tell patients that there will be some anterior pain if the patient's age is less than 50.
Okay, the same way the last question for all of you because the time end up.
Okay.
So for your cutoff for the osteotomy, how much you accept in the lateral compartment and patellofemoral joint?
So lateral compartment has to grade 1, maximum grade 2. Patellofemoral up to grade 3 is acceptable.
Mukesh.
I agree.
I think I agree, but I'll be I won't do for even grade 3. So it will be 1 and 2 for
Patellas, yeah.
For me, the clinical situation is the most important topic. If the patient do not complain on pain patellofemoral, I do not care about the degree of OA. In the lateral compartment, I would accept grade 2 if they have no problems in the lateral compartment. If they have degree 3, it would be critical.
Because that's very, very value point. Because the patellofemoral joint, even though sometimes when you show arthritis, the patient may not have any pain at all. So that is very, very important. So still this osteotomy will help the patient. If you tell, anyway, this patient is not going to do any squatting in the floor after that. You are going to caution the patient that, even I don't advise any of my osteotomy patient again to do a squat. I don't encourage that. Yes, Mukesh showed all the videos of mopping the floor. Usually I don't encourage them because I know that it's going to put more stress again and give a problem. So anybody with the patellofemoral arthritis with grade 1, 2 or 3, even there is no symptom, clinically it's not correlating, still I think it would be preferable.
And we should even be aware that we have an influence with the osteotomy of patellofemoral tracking, because the direction change, and if you analyze the TTTG before and after an osteotomy, it will be different. And so we have an influence, and probably we support it. We do not know it so far, but probably we do it. Just the clinical situation is for me important, not the arthroscopic view.
Yeah, that's why this question came, because literature has shown that it's going to put a lot of pressure on the patellofemoral joint. So clinically, if they are asymptomatic, still we are okay with to go to up to grade 2. Yes,
I have
Geeta.
one question
Yes.
first from panelists. We discussed about the cartilage lesion as the threshold, lateral compartment. What about the meniscus, sir? If there is a irreparable meniscus, would we still do a ITP osteotomy to valgate it?
I think any meniscal tear in the lateral compartment could be associated with the cartilage degeneration, correct? No? So
If
when
the
you have a
cartilage
middle
is
compartmental arthritis, isolated lateral meniscal tear cannot happen unless you have a cartilage degeneration.
In post-ACL scenarios, we have like
Oh,
irreparable meniscus.
that's a different
Yeah.
scenario. So
Post-ACLs, we do have irreparable lateral
the question,
meniscus.
but this is not for the degenerative cases, but post-ACL patient comes back after 10 years with middle compartmental osteoarthritis with varus deformity. If they have a lateral compartmental OA, up to what grade you accept, you can go ahead to do osteotomy.
Meniscal lesion alone.
A lateral meniscus lesion alone without cartilage.
Sorry, if he had a meniscal lesion, sorry, can you repeat the case again?
So his question is that if you have a patient had a post neglected ACL,
Yeah.
after coming many years with the middle compartmental OA with the varus deformity along with the lateral meniscal tear, which may require a partial meniscectomy.
Yeah, I would go for realignment and adjust the meniscus. And the question is always, which other option do I have for this patient? Because the patient comes and complains, and even if the final result will be not the same than without this combination, I guess I can support and preserve the knee for some years. Probably not in the same timeline than if I do not have the problem in the lateral part, but I can support it in my opinion.
100%.
You will have two different answers. Only osteotomy guys who doesn't do scopy, they'll do it, HTO, without even thinking about lateral meniscus minor tears. We as a scopy surgeons will think whether to do partial meniscectomy. Clinically, is it symptomatic? Is he having lateral joint line tenderness or anything before you decide about it?
Correct. So most of these lateral compartmental meniscal tears with chronic cases will be asymptomatic only. So still you can go ahead with osteotomy. Thank you everyone.
Thank you.
Thank you.
Thank you, sir. I would like to thank all the panel members for the wonderful discussion.